Hi, everyone. Welcome to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the host for the Dean's Chat podcast. My guest today is a longtime leader in the educational space in podiatric medicine. Dr. Karona Mason is currently the Vice Dean at the Dr. William M. Scholl College of Podiatric Medicine. Dr. Mason received her undergraduate degree at Brown University. She has a master's degree in healthcare administration from Central Michigan. She received her Doctor of Podiatric Medicine at Temple University, College of Podiatric Medicine, and she did her residency with the North Philadelphia Health System. She joined the William M. Scholl College of Podiatric Medicine faculty in 1999, and she has had many roles throughout our profession in the education of and evolving of our educational system in podiatric medicine. Welcome to Dean's Chat, Dr. Mason.
Thank you so much for inviting me, Jeff. Thank you.
Oh, you're welcome. You know, we are kind of informal on Dean's Chat. And let's go with Karona and Jeff. We'll go first names. How's that sound?
Yes. Perfect.
All right. Sounds good. Well, Karona, you and I have known each other for a long time. And we've worked together in the educational environment, evolving, I might add. And I don't know anybody that's kind of covered as much territory as you've had throughout different courses and divisions and assistant deans and clinical education. And now you're the vice dean. What does a vice dean mean?
The vice dean may mean different things to different people, but for me at Scholl College, I see myself as a project manager in every aspect of the education, HR, recruitment. I'm just a project manager. So I kind of look and oversee, and I'm there for the associate deans, for faculty, for students, because I'm still involved in teaching. So really it's just making sure that the mission of the college and our students and faculty and my dean, that things get done the way they need to be so that we can put out a great product.
I like that.
A great podiatric physician. So that's kind of like how I see my role.
Very good. Because you don't see many vice dean positions. So I think that's gives you a lot of credit. And I know you've worked hard and you are an unbelievable project manager. I know that.
Thank you. Thanks.
So, Karona, let's go back in time. And you were getting your undergraduate degree at Brown. And you, obviously, education's in your blood because you went on to get a master's in healthcare administration. What made you decide to become a podiatric physician?
So initially, podiatric medicine was introduced to me. I'm from Washington, D.C., and it was introduced to me by Dr. Harold Glickman. Oh. And, Dr. Glickman was a board, trustee or whatever, and he was my grandmother's podiatrist. He became my mother's podiatrist. So even before I entered Brown University, podiatric medicine was, talked about. However, I was interested in allopathic, osteopathic. And then when I did a MCAT program at Georgetown, the dean there introduced me to podiatric medicine by introducing me to two students. One of them is Dr. Kirk Jeter, who folks know. Yeah. And so I just kind of made a list. I was interested in family practice. And so, after thinking about podiatric medicine, I just made a list and I found that podiatric medicine, in addition to the surgical aspect, appealed to me. And after I got my master's, I just, I jumped in and, went to Temple or PCPM at that time. And here I am.
Wow. So tell me about your 4 years at Temple.
Very interesting because at that point, podiatric medicine was relatively, I don't want to say unknown, but it was like a secret, good secret. So it was challenging. I was only 3 hours away from home, which was great. It was rigorous. And, everything that my friends that were in allopathic medical school was going through, I was, but even more because we have to take the clinical courses as well, like medicine, radiology. So, it was rigorous. It was fulfilling. And I think probably after boards, I knew that I was where I should be. So after I passed boards part one, I was like, yeah, okay. And, and going out to clerkships, I really felt like, I made the right decision.
Well, that makes sense. I tell my students even today, Karona, I said, getting through those first 2 years and passing boards part one is your ticket to the world of treating patients and all the wonderful things our profession has to offer.
Absolutely. Absolutely.
All right. So when you finished up at Temple, you stayed in the Philadelphia area for residency.
Yes.
Tell us about
Yes.
that.
Yeah. So Dr. Scott Millay was my residency director. That program was a merger of St. Joe's and Girard Medical Center. So I was fortunate in the sense that, I was exposed to St. Joseph had a 4-year program, and I was exposed to those attendings, then also the attendings at North Philadelphia Health System. So again, it was rigorous. I believe ER was my first rotation. And at that time, the hospital was affiliated with a prison system and those type of things. So I learned a lot in a short period of time. But it was, internal medicine was definitely something that DOs were at that hospital. So I got a lot of a good internal medicine background. So it was an experience. Definitely rewarding. But I got my hands truly I got my skills there. I got my chest hairs, as I say, during my residency program.
That's great. Well, I was talking to Dr. Harkless recently and getting a little bit of the history of podiatric medicine. And obviously all roads lead to San Antonio, right? Because you headed there.
So it appears.
that you headed that direction after your residency program.
Yes. I was fortunate when I finished my residency program to land a job. With with an alumnus, and Dr. Stribling, and I worked for him for a couple of years. I also worked at Humana. Humana Hospital actually had clinics. And so I worked at the Humana Clinic as a podiatrist. Then I also worked for Richard Pollack, who was Harkless also knows who Richard is. But anyway, I worked for him, and I actually got introduced to clinical trials with Dr. Pollack. So I participated in several clinical trials with him. And then after that, I really, I felt comfortable enough to open up a practice of my own. So I opened up a practice in San Antonio. I was in private practice for about 4 years before I left.
Oh, very good. It's interesting you mentioned clinical trials in the early 90s because those were the Renaissance days. That's when dermagraft was getting studied and Apligraft and growth factors, and it was kind of an explosion in the wound care space.
Yes, it was. And actually those clinical trials I was a part of. Yeah, for sure. Yeah.
I was too, and I got to know Dr. Pollack at that time too. And you remember doing all the investigator meetings and going around the country, and a lot at stake, and everybody was so excited because the wound care world prior to that was like occlusive dressings like Duoderm or just wet to dry bandages.
To die. Yeah, absolutely. Yes. And it definitely opened up several opportunities and it opened up podiatric medicine in terms of what we can do and what we can contribute. So I definitely enjoyed the clinical trials, definitely.
Absolutely. So I'm just kind of following the path of your career. So you're in practice in San Antonio. Life is great. San Antonio is a wonderful city. But you were an educator at heart and you headed back up to the Chicagoland area.
Well, yeah. And so as life happenstance, and I'm pretty obedient to opportunities, I left Texas to get married. And I was really looking at private practice, to be honest with you. I was looking for private practice. And then I ran into Tom Chang when I was in Texas. He was my suite mate in SCPM. And Tom said, hey, there's a position open at Scholl College. And Adam Landsman, who also graduated with us, is working there. And I was like, okay. And so I applied and got interviewed by a whole bunch of people. Beth Jarrett was one of them. And I, was fortunate enough to get a job at Scholl College. And so that really, that, and then I also had a position at Providence Hospital of Cook County. So I was fortunate enough to work 4 days a week at the college and then 1 day a week at the county facility, at county hospital, where I took call. So it was great, actually. It was like the best of both worlds. So my private practice need was being taken care of. And then academic medicine was something, to be honest with you, Jeff, I was very surprised that I loved it as much as I did. That was a shocker to me.
Really?
I have to admit it. Yeah, it was, because I was one of the students. I mean, I don't know. That's what I tell the students. I can tell when they look at us as attendings and go, I'm not going to be an attending. I'm going to go out, because I was one of those students. I was like, I would never be a teacher. That's what I said.
No, I hear you.
But apparently, it's in me. And so here I am, doing what I swore I wouldn't be doing when I was a student. However, I think that gave me some insight, because that's not what I started to want to be in terms of trying to have a balance between teaching students and understanding where they're coming from, because I was one of those students. I never lost that piece.
But then you were hanging around with Adam Landsman and Tom Chang, and they're very academic also, so you must have had it in you.
Well, yeah. That's true. Yep. Okay. Yeah, that's true. Yeah. Maybe something I never wanted to see. Absolutely. Yes. And Luke Ciccinelli. Yeah, Luke was in my group too. Yeah.
Oh my gosh.
I know.
Right?
I know. I was lucky.
Hey, that would make a heck of a podcast with 5 of you on it, especially with Luke, with his new role with Pike.
Yes. Oh, count me in. Yeah.
All right. Sounds good. So you said you weren't expecting it, but you got there and it really fulfilled a lot of maybe needs to teach and educate and treat patients.
Yes, absolutely. I could do all 3. And so, the academic piece, I was definitely, and Scholl, like I said, they were, I was an outsider per se, but I was really able to become a part of the team. I was able to, I had, freedom to kind of look at things and make policies and work with faculty and collaborate. So it was really good. Yeah, it was a great experience, actually.
No, that's great. So tell me about your increasing responsibilities over time, because I noticed you were overseeing podiatric orthopedics in a lot of different areas. How did that evolve? And at what point do you say, hey, no, I'm happy here. I don't need more responsibility?
Yeah. To explain, it was almost like I felt, even though I was getting different responsibilities, it still was the basic same thought process of educating students, having oversight, and also being able to teach students. So I think I never saw it as more responsibilities, honestly, until I became the vice dean. Not as much, because I always participated in education, the clinical lecturing. So really it was more of oversight, I saw it, more so than responsibility. The faculty members at the college, all knowledgeable, all are about students. And so it was easy. It wasn't like I had to, herd people to do it. Everybody had the same purpose, the same goal, the same mission. So I saw my, going from one, assistant to associate, also just increasing oversight. That's it. Associate dean of clinical, clinical was really my thing. It's really what I love, dealing with patients and all. So that was probably one of my easier for me, because I really could concentrate on what students need clinically to be prepared to go to clerkships. So I could hand it off.
Right.
At that time, Beth Jarrett was the associate dean of clerkships, and her and I worked very well together in terms of, what do you need the students to be? So let's talk about what we need to do while they're on site so they can be the best when they're off site.
It's one of the biggest challenges, isn't it? To make sure that we're presenting the best opportunities for students when they go out to clerkships to get those residency programs.
Absolutely.
All right. No, that makes sense. So you had a big fan in Dr. Bill Todd. He was a mentor of mine.
Yes.
Bill was Irv Cannett was my residency director the first year, and Bill Todd the second at Kern Hospital. And then he went to Scholl, and you had a great working relationship with Bill. Your thoughts on Bill?
Yes. Again, fortunate in the fact that I was open to, learning, to collaborate, and what Bill did for me was basically allowed me with guidance. He wasn't a micromanager. But he definitely allowed me to evolve. And the parameters were, you have to do this for the students. That was his thing. If it's not for the students' benefit, then, why are we talking about it? So I found it very, I felt comfortable enough to try to fail. I mean, it definitely was not perfect. You're just never perfect, but I felt comfortable in doing so. And so he really was supportive. And that's all really you can ask for. At that time, he was my direct report. So in each step, he was very supportive and, and really taught me a lot about podiatry and education, not necessarily by lecturing to me, but just by me observing him and actually Terry Albright, just observing their thought process, how they did things. And then, they were always open to me having a conversation. Like, this is what I'm thinking. What's your thought? What are some of the pitfalls? What should I be looking out for? And they would just give me their opinion. And then I would go and do what I needed to do. Another thing Bill taught me was the assessment piece. Scholl, and like all the other schools, because the CPM very assessment driven. If you try something, you need to make sure it's working. And if you try something different, you're going to affect something else. So you got to get ready for whatever the fallout. It's always going to be a fallout, right? You try something different, that may work, but something else may not. So assessment was something he always kept hammering. It may look like you're doing a good job, but you need to make sure that you are.
Yep.
So I was, fortunate from that perspective too.
Yeah, when I was the dean in Miami, Bill had just retired, and speaking of assessment, we brought him down to Miami to help with assessment. And Bill was phenomenal, but he did mention unintended consequences often. So we had to be careful as we were making changes. You're absolutely right.
That's right.
So that's great. Karona, you mentioned Dr. Albright. Other mentors that you've had in the profession?
Larry, definitely. Harkless. He was very supportive in the sense that if this is something that, again, is going to be great for the students. Larry used to always have a saying in his residence from a clinical perspective, would you treat your mother this way? Would you, whatever you're going to do, would you? And he would always ask that question. And it was the same thing about, is this going to benefit the profession? It's going to benefit the students. So he definitely, especially from an academic perspective, was very much a mentor in the same way that Todd was in terms of, say things to you, well, not definitely judging, but just giving you information. So from the academic piece, definitely I could call on Larry. He was also very good about exposing me to committees, I was on a federal committee, and he had recommended, that's all he could do is recommend it. And that was a great experience as well. So he's definitely one of them. To be honest with you, though, there are so many people that poured into me directly or indirectly. My colleagues at Scholl College, I'm in the Council of Faculties, and a lot of the discussions that we have for me is a form of mentoring because I would always learn things from them. And even still now being mentored. I mean, I think Dean Wu, for me, has been a great mentor as well. I mean, she'll go, oh, no, yeah, but she has. So I anytime I'm around, other of my colleagues, I learn things. And in a way, they're mentoring me. They may not feel like it based on the conversations that we're having, but it is a form of mentoring. My first, Dr. Stribling, my first job out, he was a mentor. Kirk Jeter, even though, so I take every opportunity that I have when I interact with folks to learn something and to mentor me. So.
No, that makes sense.
I mean, that's real talk too.
No, and you've had a wonderful environment to learn in. That's great.
Yes.
So this might be a loaded question, but if you were to take a snapshot of our educational system in 1999 and a snapshot today in 2023, what are the major differences you see, Karona?
Oh, yeah. Well, definitely when I was in school, the surgical piece was somewhat, limited in the sense you learned it, but it was like allopathic, only some would be able to achieve it.
Oh, fair enough.
So it was not, come on, everybody, everyone has to be on this level. They were okay with, well, maybe you're just going to do this or that. Whereas now the emphasis is we are one profession where we're podiatric medicine and surgery. So everyone now has to be at a certain level, right? Because if you're going to, do surgery on someone, you have to be more than just competent. We talk about boards competency, but, you really have to always be on your A game when you're in the OR. So those two things are major. And I think that also drove the curriculum to be a little different, just because we've changed that now it's everyone. And not, there are definitely, discussions, you may not want to do surgery when you get out, but you're going to be trained.
Right.
And if you're going to be trained that way, then the curriculum has to make sure that everyone has those basic, pre-op, that you know about medicine, that you know about anatomy, you really know about anatomy, those things that you really need to know in order to be successful in the OR. Sure. So that to me is a major difference. And the students.
Yeah, I agree with you.
Students are different.
So in what way do you sense the difference?
It's generational in a way. The exposure, I think they have more exposure to podiatric medicine. But I think because it's like, that you're going to do surgery, I think some of that, I don't want to say hustle, but I'm going to say grit. May not be as it was when everyone was kind of struggling. The class sizes were large in the 90s. It was more of a, if you get through, not you will get through. And so definitely everybody was like, oh, I've got to, I may be the one that was that. Whereas, and rightfully so, I think that students sometimes will rest on whatever their laurels are. But, medicine is ever evolving. And you have to always be prepared and you have to evolve with it. So I think that can be somewhat of a challenge. I definitely think COVID has not helped for a lot of reasons. Right. Just hasn't helped.
Let's circle around and talk about COVID in a minute. I had a question that I wanted to ask you. What's the landscape, in your opinion, for scholarly work in the last 20 years? I think it's expanded immensely to our favor.
Oh, my goodness. I could not have imagined. And students, not only just faculty, but students are very much into the research, very much into, we've definitely attracted a different type of student, I think, over the past 30 years. We definitely have, where they look at podiatric medicine as medicine. There are definitely a group of students that do that. And so I think that's why we have been able to evolve from that perspective, where students want more research. And then we've just been booming. It's incredible. I didn't foresee that when I was in school. That was not on my radar at all.
It wasn't on mine either. I got introduced to it after I got out of residency and,
so did I.
Doing clinical trials and things.
That's right. Absolutely.
Because once you see a clinical trial and you understand an IRB situation and you understand what it is to randomize patients, all of a sudden things started to come together that I was never exposed to in school. Never
exposed to. Totally agree. For me, the research was GATE.
Yeah, there you go.
And if that's not what your interest was, or the DPM PhD, the wet bench research.
Yeah.
And so if that wasn't your interest, you just kind of said, well, that's it. But no, we've definitely come a long way.
Absolutely. You had mentioned you're on the Council of Faculties.
Yes.
And that's just been a phenomenal group within the American Association of Colleges of Podiatric Medicine.
Yes.
Can you talk about your experience on the Council of Faculties and maybe have a little discussion around the curriculum guide, things like that?
Oh my goodness, yeah. Double A and Lori and her team. I started. My God, I got put on that 2000 and something. But it really is a great group of faculty, and I hopefully the deans know that each representative that they've sent really contributes. It's almost like a safe space, and we really talk about curriculum and students and the need to be the best. What's nice about it is that, it's for all of the schools to be the best. We just had a meeting, and the Texas school representatives from the Texas school were there. They felt welcome. I mean, and we started out the meeting with, hey, this is a safe space. We're here to educate. So that's one of the great things about it. We get along in the sense that we're social. We have dinner together, and then we do debate back and forth about what we think the needs are of the students. And what's also great, it's made of basic biomedical science and clinical. So it's a great combination. The curriculum guide came up because we were like, hey, we all need to be on the same page. And from my recollection, we had to present that, I think, at the time to the deans. We had to get permission. But I think it was just very refreshing to know that we all wanted to work together. We felt that our students should all learn what they need to learn. It was not that same type of competition, just wasn't there. Curriculum guide was a lot of work. People spent a lot of time reviewing, discussing, debating, and then you were able to get colleagues from your colleges involved. So I'm very proud of it. I mean, I know the schools now, they use it when a new faculty member comes in. They go, look, here's the curriculum guide. These are the things you should be teaching. We talk about the 4s and the 3s. We've been in constant conversation with NBPME about, hey, this is what we're looking at. This is what we think is important. So I'm really proud of the work that the Council of Faculties did with the curriculum guide and how far it's progressed, and also the acceptance of the deans.
Yeah.
I mean, if we didn't have the backing of the deans, it wouldn't go anywhere.
Right. Well, I think the deans appreciate the need and are respectful of the faculty, and this is so important. Do you mind, for our audience sake, talking about the 4s and the 3s and what NBPME is?
I'm sorry. Yeah, the National Podiatric Medical Examiners. So, taking boards part 1 and boards part 2, it's a lot of information, a lot of material. So we got together in the different subject areas and said, okay, what's the most important thing that we know they need to know to practice? And those were the 4s. And then, okay, we went from 4 to 2. And so we were like, okay, 4s and 3s, everybody needs to be doing this. Now, some faculty members said, well, I think this is important. And everyone may not, but then that doesn't mean you can't put it in the guide. It's just going to have a lower number.
Right.
And so that's an option, because you don't want to take away faculty's ability to educate as they seem best, but faculty members need a guide. And especially once we start merging with osteopathic schools, it became extremely important for everyone to kind of understand, those that were in podiatric education for a long time kind of understood that. But then once we start merging, like, okay, well, if I'm teaching osteopathic students this, and this is very important for us, I need to know what's important for podiatric medicine. So that really, and it was a lot of debate. I mean, that was good, actually. And I think it made things even more clearer to people who were teaching. So that's kind of got us where we are now for boards part 1, and we have the same guide for boards part 2. The clinical didactic courses.
Yeah. And, it's interesting, you talk about collaboration. Even the clinical skills exam, which was halted during COVID, we're talking about attestation by the deans and sharing information and how we're going to assess our students from a clinical perspective, all working together. So I think maybe that's a carryover to the example the faculty set in the curriculum guide.
I think so too. And I understand because I've been involved with admission and recruitment probably about 15 years or so. But that's real in terms of wanting to make sure that folks get the best students and all that. So I don't think initially a lot of the not saying anything was really it's just more so survival than it was, I don't want you to know. And so, but I think we've gotten over that. I really do. I think we're all kind of like, hey, we are podiatric physicians that focus on podiatric medicine and surgery. And I think we've finally all come to that conclusion, and we're comfortable with it. I know when we first went into podiatric surgery, I know there were a lot of still like, yeah, I'm not sure. But now I think we're all together and moving forward. So I don't know, it's I mean, we've got some issues with recruitment, but I think it's a good time to be in podiatric education, actually.
No, I
agree.
I agree with you. So that's kind of a nice little segue into, as you mentioned, student recruitment. Karona, if a undergraduate student stops by and they're contemplating a career in podiatric medicine, what do you tell them?
I really kind of start off trying to figure out, why they want to do medicine in general. Allopathic, osteopathic, dentistry doesn't matter. Because with that, that's the first thing. Like, why are you interested in health career? And once I get a thought process that surgery is something that they're interested in, that orthopedics may be something that they're interested in, then I say, have you thought about, do you know about the career of podiatric medicine? And they go, well, kind of. And then I will talk about the profession. And basically what I tell them is that, you have the same opportunity as an allopathic, osteopathic PA to have a career where you can treat patients, you can do academic medicine, you can do research, and you can move in and out. Very flexible. And so it's the same thing. So it's just about, if you want to do surgery, are you okay with the lower extremity? Right. And so I kind of like make them do an assessment first before I even give them the spiel on podiatric medicine. I just kind of help them make an assessment on what's open to them and what it is that they think they want to do.
I do the same thing. Another factor I'm finding is the students are coming into interviews saying, I like podiatric medicine because I know what I'm going to be in the future. You're not going through the medical traditional education where then you don't know what your specialty is going to be.
Right. And that is appealing to those that even know about us. That is definitely appealing. And I think back, I'm not even sure if they know until such time they're exposed to it. And once they're exposed to podiatric medicine, absolutely. Sometimes, you just need to expose them and you don't need to say anything else to them. Right. They're filling out their application, they're contacting people wanting to shadow. So yeah, I can see that being very important to students.
Well, and also not knowing what you're going to be is important, because if somebody goes into osteopathic medicine, for example, and they don't want to be a primary care physician, they need to realize that 70% of the graduates from the DO programs are primary care
physicians.
Yeah. So I
think
if
they want to do a specialty, right? And that's why with ortho, especially I found when I used to recruit, I used to be able to recruit a lot of females.
Okay.
Who wanted to do ortho.
Right.
Because they're like, wait a minute, you mean I can do this in 3 years? Oh, wait a minute, I can, do bone surgery, but I could be only the foot and ankle. What do you know? This is different than what, and how can I say, female friendly, female friendly. So you're right though. I think for me too, because I was only interested in family practice, the surgery appealed to me. Like, oh, yeah. I can see that.
Traditionally, podiatry has been a very male-dominant profession, but like at my school in Arizona, we only have 40 students, but greater than 50% of them are female right now in the incoming class.
That's the trend. That is the trend. Yes. I thought I kind of saw a dip when we first said that we were a surgical profession.
Okay.
When that first came out.
Yeah.
I personally saw women like, I'm like, no, you don't. You do the surgical residency, but once you finish, you do what you do. But yeah, that's a trend. Yeah. Even in academic medicine, we have just as many females as we do males.
Right.
Yeah.
Well, it's true in accounting, it's true in law. Across the board.
Yeah, that's true. Yeah.
So you had talked about COVID for a second. The further we get away from COVID, the more I'm latching on to the good things that have come out of it. For example, you and I sitting here on Zoom like we're sitting across the table. Our students being able to do distance learning where it's the norm, not an anomaly, right?
Right.
Things like that I think have really helped, Karona. What are your thoughts?
Yeah, I really would not have imagined what we have been able to do from a technology standpoint of getting students to learn clinical things. I definitely see where Just like with the rest of the society, we're now able to have hybrids. We're able to have choices. However, I do think that just like in any other profession, I think sometimes for some students, it's easier to kind of zone out.
Yeah.
Easier to like, oh yeah, okay, because I can't really see you.
Right.
When you're in a clinical setting, when you're in clinic, I can look dead at you and tell whether you got the information. And then I say, let me repeat it to myself. I go, let me just say this again, because I'm not sure if you have it. When you're in a classroom setting and you have 80 students and, you can't see them all, much harder than when you're in person with them.
Yeah.
However, if you have a student for whatever reason and is not able, to be in class, then you have this option. And we didn't have that before. So it's not even like it's a mixed bag. I think like everything else, there are pros and cons, and it's our job to use it to the best, to make it work the best for our students and for faculty. I mean, you may have faculty members that, before, if you had to be at two places at one time, then you would have to say, well, you can't lecture. Now, say, I have to be at this conference, or I have to, to give a lecture, but it doesn't interfere with me giving the lecture to the students. You can do it on Zoom.
Right. Absolutely.
You can. Yeah. So, I mean, I definitely think it's just about making the most of it and assessing. When you do try it, you need to assess, is it really helping? More so, not you, but do the students feel as though it's optimum learning for them? Right. And so once you find it's optimum learning, then I would keep it.
Yeah, it's interesting because the didactic sections I can see smoothly, working. It's when we start doing clinical biomechanical exams, you're doing basic skills, you're doing a physical exam, you just can't do it like we're talking right now. So they need to be there. There's no doubt about that. But we need to, like you said, there's a time and place for everything. I think that's a fair.
Yeah, and then you can, something I used to always think about is a possible prep. You know how they talk about when you do simulation, you have to, afterwards you say, okay, what did you learn? I've been thinking about the prep for clinic. Yeah. Like I always tell students, you need to prepare before you come. I'm like, oh my God, one more thing to add. Students will be so mad at me, but is there a way if you want to prep on Zoom?
Right.
This prep what tomorrow may look like. Can you prep with each other?
Sure.
So you're right. When you're doing hands-on, no, but definitely thinking, thought process, clinical skill set, and also Zoom sometimes can be a safe environment.
Yes, true.
Because they're not with you. They're not, you can't look at them. I remember during COVID, I had all the students and I used to say, look, let's come up with some differential diagnosis. I don't care how crazy it is. I just want to hear you talk.
Right.
Just say, and they start talking. And it was much more freer than when we were in person.
Yeah.
So you're right. It can be used. COVID did some great things, actually, in my opinion. And it definitely revolutionized education. I think we just have to find that sweet spot.
I think one of the sweet spots when you're having a meeting with faculty, for example, is that you all put your camera on. So it really does feel like you're in the same room, because I got a sense, and I know it's human nature, right? If your camera's not on, you start doodling or looking at your phone or something. I think that's human nature. So I think that's one thing that we can all improve upon.
Yeah, absolutely.
So the last thing I wanted to talk about, Karona, and this is a profession-wide effort, the Feet on the Street, a student recruitment initiative. All 11 schools are involved. The leading entities in our profession, whether it's the American College of Foot and Ankle Surgeons, American Board of Foot and Ankle Surgery, PICA, for example, ABPM. I mean, all of these groups are coming together to help us as universities of schools and colleges of podiatric medicine make visits to do increased recruitment efforts. Your thoughts on that?
My goodness. First of all, and I've said this to you before, but thank you for getting us all together, because I think this is the first time that I know of that there has been a recruitment effort where we have financial backing and where we're all on the same page, and it's a concerted effort at one time. So I'm very excited. I mean, irregardless of going 1 times, 2 times, 3 times. It's almost like we're going to hit the entire United States and talk about podiatric medicine. Granted, we're going to talk about our own colleges, but I think hitting it at one time is just as great as some kind of marketing. It's a marketing tool. So I'm excited. I think, again, the assessment piece, I think any time that we've touched that place, I don't care if a student really decided to apply because of their uncle, it doesn't matter. The fact that there was someone at the college, there was a faculty member, there was a DPM, colleges are now like, we're going to do it because we have finances. I really think that's the big deal. I mean, I just think that we're going to really see the fruits of our labor. It may take a couple of years, 3 to 4 years, and that's normally the recruitment trend. But I just think the branding that we're talking about, we're going to do our own branding. Yep. We don't need a spokesperson. We don't need, we've had all these different people talk about, I think we will be the branding, who we are. And I'm pretty excited about it.
Yep. And I bring it up, I wanted to give a little kudos to the AACPM staff.
Yes.
Maury, David Green, Derek, Jen, all of them have worked so hard to put this together for our benefit, and I just wanted to give them a little shout out.
Definitely. And we were in Council of Faculties. I mean, when we knew that we were going to have issues, I mean, Maury, Kelly, I mean, they were there looking like, what are we going to do? I mean, when we had those conversations, because Council of Faculties under AA, they were definitely like, okay, we've got to fix this. What do you guys want? What are we going to do? And so it's been seamless too. I mean, all of us met. It seems to be an easy process. I think we're getting great direction. And it's very collaborative. So I second Maureen, David, the SAOs. Mm-hmm. I think it's going to allow them to get closer. So I'm very excited about this. So, I mean, honestly, Jeff, if we didn't have this happening and if AA didn't take the lead with this and if we did not have the organizations contributing to us, I would be a little worried about the profession, to be honest with you. Yeah. So kudos to everybody. Thank you.
I'm with you. Somewhere Bill Todd's very happy because we put the assessment piece in with the project management software.
Absolutely. Yes. Just, is it working? Because that way, when you go back and ask, you have something to show. And honestly, there was the federal committee I was on. I can't even remember the name of the committee now, but it was best practices. And podiatry was actually in the allied health section. That's another story. But anyway, it was best practices. And in order to get federal money for these best practices, they had to come and present, and we had to talk about it. But the federal government says, where's your assessment? We're not going to give you money unless you give us the assessment. And so it makes a lot of sense. Why throw money away when it's not working? And maybe it just needs to be tweaked.
Exactly.
Yeah. So I'm pretty excited. And I think the expectations are realistic. And so we'll see.
Yep. We'll make the most of it. At least there's not going to be any shortage of effort and intent. That's for darn sure.
I love it. I do.
Well, Karona, I want to, on behalf of the profession, thank you for all you do, all of your contributions to the education of our great profession. And I wanted to let you know we're going to send you one of these Dean's Chat cups to help you get through the Vice Dean days, right? The long days.
Absolutely.
And in terms of our listeners and viewers out there, if you're on YouTube, please become a subscriber. And if you are listening on Spotify or Apple Podcast, we'd love for you to give us a 5-star rating. And until next week, everybody, cheers.